First, we're going to talk about kidney function and what the kidneys do for us to maintain homeostasis. You can remember kidney function by the mnemonic a wet bed. The kidney is basically a filter for our blood. Okay, so the first letter in the mnemonic is A for acid-base balance. Our kidney is trying to keep us in homeostasis. So it makes sure that the body isn't too acidic or too basic. Okay, so it keeps our pH in the normal range. W stands for water removal. The kidney, obviously, the kidney is involved in urination, making urine. So it helps us remove water from the body. E stands for erythropoiesis. So the kidney manufactures a hormone called erythropoietin. And erythropoietin stimulates the bone marrow to make red blood cells. Okay, and like say in times when your blood cells are low, you would secrete more erythropoietin if your kidney is working properly. T is for toxin removal. The kidney helps remove toxins such as urea and ammonia from the body, but also medications. It helps us clear medications. B is for blood pressure control. So the kidney helps us maintain blood pressure so that it's not too high or too low. E is for electrolyte balance. The kidney helps us maintain our electrolytes in the right normal range. And then D is for vitamin D activation. So the kidney helps us activate vitamin D in the body so that we can have strong bones and teeth. Our kidneys receive 20 to 25% of our cardiac output. So what that means is somebody, like say, has a dysrhythmia or they're in shock, their kidneys are not going to be perfused. That's why that's one of the assessment findings we always look for when somebody is having a low perfusion state. We want to know if the kidneys are being perfused, if they're putting out urine. So the kidney is also highly vascular. To give you an example, you don't have to memorize this or anything, but the renal artery, 1,200 mLs per minute of blood flows through the renal artery. That's per minute. So think of an IV bag. That's 1,000 mL. So add a little bit to that, and that's how much blood is going through your renal artery per minute, okay? And then the renal artery divides to form the efferent arteriole. And I promise we're not going to go that deep. I'm just going to show you a few things about the anatomy and physiology of the kidney. The nephron is the basic functional unit of the kidney. I promise I'm going to make this painless, okay? The glomerulus is in the center of the nephron, and Bowman's capsule is around the glomerulus. Now, the glomerulus is a network of capillaries, and it lets small molecules of water and waste products to pass through from the blood into the urine. It prevents the larger molecules, such as protein and red blood cells, from going into the urine. So you know if somebody has red blood cells or rusty colored urine or smoke colored urine, or if they have protein in their urine, you know that there's something wrong with the glomerulus or the kidney, okay? Urea and creatinine can also filter through the glomerulus, and that's a good thing because we don't want urea, like our BUN and creatinine, to get very high because we can become uremic, and I'm going to talk about that a little bit later. Glucose spills into the urine if the sugar is greater than 220 milligrams per deciliter, okay? Infiltrate, which is what filters through the glomerulus, blood, into the urine, okay, travels in the tubules and becomes urine, okay? So that was pretty painless, right? But you learned that you should not see large molecules in your urine, protein and red blood cells, okay? And that you should have a normal BUN and creatinine if the kidney's working properly. Okay, the glomerular filtration rate is the most accurate measure of kidney function. The normal is, and this is for young people, 125 mLs per minute. That's a normal glomerular filtration rate. It's mirrored in a lab test called the creatinine clearance, for which you have to do a 24-hour urine, and you know all the interventions from that because you learned about it last semester. Um, it also is decreased in kidney disease. So the BUN and creatinine increase and the glomerular filtration rate decreases. And as you age, it decreases as well. The filtrate that filters through the glomerulus makes its way down the tubule system, okay, and becomes urine as is going through the tubule system. Now, I just want to tell you a few things about the distal tubule. You don't have to memorize them, but it secretes potassium for us because we lose potassium in our urine, and that's going to be important when we talk about kidney disease. It also secretes H ion, which means we lose hydrogen in our urine. Remember, that's acidic. So we lose acid in our urine. And ammonia, we also lose that in our urine. It helps us reabsorb water under the influence of ADH, antidiuretic hormone. And bicarb helps us reabsorb water in bicarb. So if we're not able to reabsorb water in bicarb, we could be dehydrated, we could become acidic, okay? Aldosterone helps us reabsorb sodium and excretes potassium. So if the distal tubule can no longer do this, you're going to have a high potassium. And then remember, parathyroid hormone is released when calcium is low because it helps make the calcium level increase. And that's due to tubular reabsorption of calcium in the body. And it decreases the reabsorption of phosphate. So anytime you're talking about calcium and phosphorus, they're opposite. They're opposing, right? Calcium's low, phosphate is high, and if phosphate is high, calcium is low. Now I'm going to take you through the wet bed again, but I'm going to go over the assessment findings if the kidney's not working and also the nursing interventions that you would do for that assessment finding, okay? So as you recall, A stands for acid-base balance. So if the kidney can no longer secrete H ions into our urine, they're going to collect in the bloodstream and we're going to become acidotic, and that's metabolic acidosis. So a low pH and a low bicarb, okay? Your patient may develop Kussmaul's respirations to try to compensate for that metabolic acidosis by blowing off PaCO2, okay? The treatment for this would be hemodialysis or fix whatever kidney problem the patient is having, if that's even possible. W stands for water removal. If the kidney cannot help remove water from the body, your patient is going to have signs and symptoms of fluid overload. And this is very dangerous. And we worry about this the most, okay? So your patient can develop crackles, tachypnea, tachycardia, usually the first sign, shortness of breath, dyspnea on exertion. With pulmonary edema, they can develop pink frothy sputum, low O2 sat, and a soccer. That means all over body edema. Also, sometimes, the skin under your eyes is like the weakest skin in your body, or it's not that tight. So if you're going to have like edema, sometimes the first time you'll see it is under your eyes. They'll be puffy. Feelings of impending doom. Anytime somebody has a low O2 sat or they're hypoxic, they could have feelings of impending doom. And vein distension, like jugular vein distension, they could have that as well. First thing you're going to do is you find somebody short of breath and with pulmonary edema is you're going to get that head of the bed up, okay, before you put on oxygen. They may need furosemide if the patient is still making urine. Some people have kidney disease and they're anuric, meaning they have less than 100 mLs of urine output per day, or some people have no urine output per day, okay? So you wouldn't give furosemide to them because then that would stay in their body and it could lead to like hearing loss, right? Furosemide can be detrimental to your hearing. Morphine is a great, great, great drug for pulmonary edema. It helps relax people's breathing, anxiety, helps dilate the pulmonary vasculature. So it's a very good drug for pulmonary edema. Aminophylline, we don't really give that much anymore. But that helps dilate the bronchioles and helps them breathe better. Digitalis helps with the pumping of the heart so it can be more efficient. But keep in mind, if your patient has kidney disease, with all these drugs, they could become toxic from it because they have trouble removing the toxins from their body. Okay. And then if they're not making urine, they're anuric, they'll have to have dialysis to get that fluid off. And when people have kidney disease, as it progresses, they do have to be on a fluid restriction. Okay, E is for erythropoiesis. I mentioned that the kidney manufactures erythropoietin, the hormone responsible for helping us stimulate red blood cell growth. So if our kidneys can no longer do this function of erythropoiesis, um, your patient's going to become anemic, okay? And remember, with anemia comes fatigue, pallor, and shortness of breath. And they could have behavior called pica, where they chew ice or other non-type foods, okay? The medicine for that is epoetin alpha. There are some nursing implications of that. For example, you would assess for a headache, hypertension. Patient could have an MI or a DVT due to epoetin. So you would monitor for all those. You want to encourage your patient to alternate rest with activity to manage the fatigue that comes with anemia. Oftentimes, like with renal patients, when they get epoetin and they start producing more blood cells, they start to feel a lot better and less fatigued. They become more interested in sex with their partners because they're feeling like they have more energy. So it's a really good drug for them. You just have to monitor for the side effects. Also, it has to be refrigerated, and you stop when the hemoglobin gets to 11. Okay, so if it's 11, you're probably going to call the provider and say, "Hey, do you still want me to give it?" Okay. T stands for toxin removal. So our kidneys help us get rid of urea and creatinine in our body. It helps us get rid of medication, right? They're eliminated by the kidneys. So people that have kidney disease are going to have high BUN and creatinines, which is going to cause uremia, which causes confusion. So we decrease protein in the diet to help with that. It's going to make their skin very itchy and have a sallow color. Sallow color is a yellowish tan gray undertone. Okay. And if you ever see somebody with renal failure, end-stage renal failure with that color, they kind of almost look tan sometimes. You'll never forget it. Okay. VAN, that's one of the earliest signs of uremia. It stands for vomiting, anorexia, and nausea. Uremia is toxic to our mucous membranes and also our serous membranes. So the patient could have stomatitis, which is, irritation inside the mouth and the mucous membranes. They can also develop ulcers, gastric ulcers, sorry, I should have said that. They could develop diarrhea due to irritation of the bowel, and pericarditis due to the irritation of the pericardium. Um, and with medication toxicity, like, let me give you an example. Say, oftentimes, renal patients are also diabetics, and say they're taking insulin. You may have to start to check the blood sugars more because the insulin's going to more frequently, sorry, because the insulin's going to stay in their body longer. Okay, so keep that in mind. And they're taking digitalis, they can get toxic from that. So just keep that in mind, that they can get toxic from drugs. B stands for blood pressure control. And this is kind of a chicken and egg situation because having uncontrolled hypertension is probably one of the main drivers of kidney disease. But also kidney disease causes high blood pressure. So patients with kidney disease need very good hypertension management. Oftentimes they're put on an ACE inhibitor early to decrease protein loss in the urine. And and also help with blood pressure. They can be prescribed calcium channel blockers and beta blockers as well. Just a note of caution, those that are prescribed ACE inhibitors and ARBs, those can increase potassium in the body, which also happens with kidney disease. So it can also, when it's given to patients with kidney disease, increase the potassium further. So watch for that. Okay, for electrolyte imbalances, this is like, there's going to be a lot of electrolyte balances if somebody has kidney disease, because the kidney cannot no longer remove potassium through the urine, okay? So the patient is going to have a high potassium and they're going to suffer from dysrhythmias because of this. So you always want a patient with kidney disease and a high potassium to be on a monitor. They're going to have high phosphate levels and low calcium levels. And this is going to lead to osteodystrophy, which means patients with long-term end-stage renal disease, they could like break a bone just by hitting their hand on, like, say, the bedside rail, okay? That's how weak their bones become over time. And then with magnesium, we worry about, heart problems as well. And we need to be on a low sodium diet for people with kidney disease as it progresses. For high potassium, remember the mnemonic kind. So Kayexalate can be given, which is also called polystyrene sulfonate, which was probably on your exams. And insulin and dextrose helps drive potassium in the cells. Bicarb as well. You never want to give patients with high potassium salt substitutes because they're high in potassium. And then they may need to have dialysis if they're not making urine, if they're not producing urine anymore. But if they are producing urine, they may get diuretics to help with that. For high phosphate, they're going to take phosphor binders with all meals, so Celavir, or aluminum-based antacids. And they need to avoid high phosphorus foods like dairy, soda, nuts, okay? Low calcium, encourage calcium in the diet. They may take vitamin D3, that will help with the calcium absorption. And then for high magnesium, avoid giving magnesium containing antacids such as Milkomag. So vitamin D is also going to be low, which is going to result in low calcium. And your patient can develop osteodystrophy, which I talked about. So they're going to need vitamin D3 supplementation. Okay, one more time, just look this over one more time. A wet bed tells us what the kidney is supposed to do. If the patient has kidney disease, they're going to get the conditions that are in the parentheses, okay? I really want you to take some time and reflect on this, because if you can learn this, and when we get into kidney diseases, it's going to be like, oh yeah, of course that would happen. If the kidney's not working properly. Okay, so it's really important that you reflect on this. Okay, the urinary system. So each kidney, attached to each kidney is a ureter about 9 inches long, okay? The bladder, and it attaches to the bladder, which is a muscular organ, hollow muscular organ, which holds our urine, about 500 mLs. And if you just look real quick here, you notice that the female has a shorter urethra, which is why we're more prone to urinary tract infections, because the bacteria doesn't have that long to go, right, to infect us. Whereas if you look at the male urethra, it's a lot longer.